Hello, hello, hello. My name's Cheryl. I am a registered nurse with 20 years of experience in the critical care field, specifically CVICU or cardiovascular intensive care, surgical care. So I'm here today to do 10 Question Tuesday, and I'll be answering some questions about recovery from anesthesia and pharmacology support following cardiac surgery. Okay, let's get started. Number 1. A patient develops cardiac tamponade following cardiac surgery. Which should the nurse initially anticipate? Keyword initially. Administration of fluids, preparation for pericardiocentesis, titration of vasopressors, or performing a 12-lead EKG. Well, the answer is administration of fluids, which is A. The rationale is that fluids are needed to help counteract and decrease the preload from the associated decrease in diastolic filling pressures associated with cardiac tamponade. So you need something to kind of fill or push back on the fluid that's already accumulated around the heart. So you need some volume in the heart, basically. Number 2. Patients who receive midazolam in the OR should be observed for A. Tachycardia, B. Respiratory depression, C. Vasoconstriction, and D. Post-operative nausea and vomiting. Okay, B is the answer. Respiratory depression. Rationale: midazolam can cause respiratory depression. It can also cause bradycardia and vasodilation, and it minimizes development of postoperative nausea and vomiting. Midazolam is also known as Versed. We commonly use that to sedate people. Conscious sedation, it's used in a lot of the times. Okay, number 3. A cardiac surgery patient is admitted directly from the OR with an initial temperature that was... I forgot to put my earpiece in. Sorry. So the options are A, SVR of 900, blood pressure 88/50, CVP 9, heart rate 120. The answer is the heart rate. Tachycardia is associated with hypothermia, as is an increase in the SVR, hypertension, and a decrease in the preload. Number 4. Which is a potential effect of postoperative hypothermia? A. Decreased myocardial consumption. B. Increased infection risk. C. Increased clot formation. Or D. Decreased need for transfusions. The answer is increased infection risk. A rationale is there is an increased risk of infection with hypothermia, as well as an associated increase in myocardial oxygen consumption, disruption of the coagulation pathway, and an increased need for transfusions. Okay, number 5. Post-extubation, a patient develops rocking respirations, tachypnea. Tachypnea, stridor, and use of accessory muscles. The initial nursing intervention should be to A. Prepare for reintubation, B. Suction the oropharynx, C. Encourage the patient to cough, D. Administer a short-acting neuromuscular blocking agent. Well, the patient is extubated, so you won't give them a neuromuscular blocking agent that will just make them totally not able to breathe. So you know that one's wrong. The answer is C. Encourage the patient to cough. The rationale is coughing may eradicate the patient's partial airway obstruction. And intubation is not the initial intervention that is indicated and may not be able to be accomplished due to the narrowing of the upper airway. Suctioning will not correct the patient's problem. A short-acting neuromuscular blocking agent may ultimately be required, but is not the initial intervention. So that's the difference. All right. 5 more questions to go. Hello, everyone. A patient is receiving a low-dose epinephrine infusion. A patient that's receiving a low-dose epi infusion should be monitored for what? A, serum glucose of 286. B, serum sodium of 130. C, serum lactate 1.2. And D, bicarb of 26. The answer is a serum glucose of 286. Rationale, patients on low-dose epi drips may develop a metabolic acidosis, low serum bicarb levels, hyperglycemia, lactate buildup. Not only that, epinephrine is usually mixed with D5, not normal saline. So that, I guess I know low doses means low volume too, but you have that extra glucose there. All right. The next question, which should the nurse anticipate when administering milrinone to a patient with ventricular failure following cardiac surgery? A, SPR 900 to 1100. B, heart rate 90 to 136. C, pulmonary artery occlusion pressure 16 to 12. And D, MVO2 35 to 20. The answer is a pulmonary artery occlusion pressure 16 to 12. The rationale is milrinone produces venous and arterial vasodilation, and it decreases SVR, PVR, and PaOP, while minimally affecting myocardial oxygen demand and heart rate. It increases stroke volume and cardiac index and output by producing vasodilation in vascular smooth muscle, and by decreasing intracellular calcium concentration. So you use it a lot in heart failure patients. The next question, the nurse should observe for which after administering methylene blue to a patient following cardiopulmonary bypass surgery. PaCO2 50, temp 35.1, SpO2 81%, heart rate of 56. The answer is 81% SpO2. So the rationale, the 2 main side effects of methylene blue are hypertension and a brief period of artificially low oxygen sat on a pulse ox. Other side effects include hypotension, abdominal pain, dizziness, headache, confusion, nausea, vomiting, and diarrhea. Serious adverse events include cardiac dysrhythmias, malignant hyperthermia, and methylglobomania. I'm not sure what that is, but I guess I should look it up, right? But that's the answer. Okay. Number 9. A patient with cardiopulmonary bypass induced inflammatory response is to receive hydrocortisone for hemodynamic instability, for which should the nurse observe? A, fluid retention. B, serum glucose of 56. C, serum sodium of 130. Or D, serum potassium of 5.8. So this is what's the side effect of hydrocortisone, essentially, is what we're asking. The answer is fluid retention, A. Rationale: side effects of hydrocortisone include insomnia, hyperglycemia, delirium. Potentially serious side effects or adverse events include hypertension, edema, headache, seizure, mood swings, bruising, hypokalemia, sodium and water retention, abdominal distension, Cushing syndrome, stress ulcer development, and immunosuppression. That's a lot of side effects. But it was my experience, I noticed that, patients have a lot of mood swings. They cry, they get anxious, they're just moods all over the place usually after hydrocortisone, especially high doses of it. The last question is, a patient is to receive Naloxone or Narcan for opioid-induced respiratory depression. For which should the nurse observe? A, sinus bradycardia. B, first-degree AV block. C, atrial flutter. D, ventricular fibrillation. The answer is D. And the rationale is the side effects associated with Naloxone are rare, but include cardiac dysrhythmias, tachycardia with hypertension, hypotension, ventricular fibrillation, and pulmonary edema, and hepatotoxicity. But I guess all of that balances out, with my patient has a depressed respiratory drive, and I wanted to figure out if it's Narcan can help. I would go ahead and use the Narcan. Just keep the code card close by, and your provider's close by when you're administering it. So they use that a lot out in the field to reverse these narcotic, or try to reverse somebody who's overdosed on something like fentanyl or any or narcotic. Those are my 10 questions for today. I hope it was a helpful review for you. I will be back on Thursday to do another 10 questions. You can connect with me. The link is in the bio to Instagram. Through Instagram, Facebook, and I have other links on there too as well. And that's it for tonight. If we don't have any more questions, thanks, Creative Acclamy. Good night.